Now let's talk about sympathomimetics. So for the sympathomimetics, please remember that there are two groups. So first of all, we're going to have direct acting ones, and then we have indirect acting ones. So for the direct acting ones, just remember alpha agonists and beta agonists. So for the indirect acting ones, just remember releasers and reuptake inhibitors. For the alpha agonists, we are going to have for the three types, which are alpha 1 selective, alpha 2 selective, and non-selective. For the alpha 1 selective, please remember P, and for alpha 2 selective, please remember C. So PC. Alpha 1 selective example is phenylephrine, alpha 2 selective example is clonidine, and non-selective example is something that starts with an N, which is norepinephrine. For the beta agonists, let's talk about the beta 1 agonist, and then we're going to talk about beta 2 agonist, and then the beta 1 selective, beta 2 selective, and then the non-selective. So for the beta 1 selective, please remember dobutamine, and for the beta 2 selective, please remember albuterol, which is an inhalant. And then for the non-selective, please remember isoproterenol. Indirect acting ones, please remember releasers and reuptake inhibitors. So for the releasers, we are going to have amphetamine. For the reuptake inhibitors, we are going to have cocaine. Okay, now let's talk about the spectrum of action of some of the drugs. So adrenoreceptors are further classified as alpha, beta, or dopamine receptors. These groups are further subdivided into subgroups. The distribution is given, and so epinephrine may be considered a single prototype agonist which have effects on both alpha receptors as well as beta receptors. However, if we talk about phenylephrine, it is only an alpha agonist, and isoproterenol is a beta agonist. They have very little effect on dopamine receptors, but dopamine itself is a potent dopamine receptor agonist, and when it is given as a drug, it can also activate the beta receptors in intermediate doses and alpha receptors in larger doses. For the mode of action, sympathomimetic agonists may directly activate their receptors, or they may indirectly activate their receptors by increasing the concentration of the ECT, or the endogenous catecholamine transmitter, in the synapse. So amphetamine derivatives and tyramine will cause the release of stored catecholamines by indirect acting. They are mainly indirect in their mode of action. If we talk about cocaine and antidepressants, then they will exhibit another form of indirect action because they are reuptake inhibitors. They are going to inhibit the reuptake of catecholamines by the NET or the DAT, which is the norepinephrine transporter, or the and the dopamine transporter in the nerve terminals, and they will increase the synaptic activity of the release transmitter. The complex actions of the antidepressants or amine reuptake are discussed. The blockade of the metabolism, which is blockage of the COMET or the MAO, which is catechol O methyltransferase or monoamine oxidase, that has little direct effect on the autonomic activity, but monoamine oxidase inhibition increases the stores of catecholamines and related molecules in the adrenergic synaptic vesicles, and this potentiates the action of the indirect acting sympathomimetics or amphetamines that causes the release of the stored transmitter. Catechol O methyltransmitter inhibitors are useful in Parkinsonism. Okay, so anorexia is a drug that decreases appetite, that is, it causes anorexia. Catecholamines are dihydroxyphenyl ethyl amines, for example, norepinephrine and epinephrine. They are relatively polar, and they are readily metabolized by catechol O methyltransferase or COMET. So what about decongestants? Decongestants are the drugs that decrease vasodilation of the conjunctival, oropharyngeal, or nasal mucosa by constriction of the blood vessels in the submucosal tissue. Mediatrix are going to cause the dilation of the pupils, opposite of miotic. And then if you talk about phenyl isopropylamine, they have the structure of isopropylamine, and they have oral activity and a longer half-life and CNS activity, and they cause release of stored catecholamines, unlike the catecholamines. And then if you talk about the selectivity of selective alpha or beta adrenoreceptor agonists, they are the drugs that have relatively greater effects on alpha or beta adrenoreceptors, but none of them are actually absolutely selective or specific. If you talk about sympathomimetics, then these are the drugs that mimic the stimulation of one or more components of the sympathetic autonomic nervous system. What are reuptake inhibitors? They are indirectly acting drugs that increase the activity of transmitters in the synapse by inhibiting the reuptake in the presynaptic nerve ending. For example, cocaine and many antidepressants. They act selectively on noradrenergic, serotonergic, or both types of the nerve endings. Now let's talk about the types of adrenoreceptors which are outside the CNS, some of the peripheral tissues in which they are found, and their major effects. So first of all, let's talk about alpha 1, alpha 2, beta 1, beta 2, beta 3, and D1, D5, D2, D3, and D4. Okay, so when we talk about them, please remember the mnemonic of ENHAS. So for that, we have this. This is for the alpha 1, alpha 2, beta 1, 2, and 3. England never have some pathology. So E is for the effector cells, including the smooth muscles and glands for the alpha 1. So alpha 1 is going to act on the smooth muscles, including the pupillary dilator muscle and the pilomotor smooth muscle, and most of the vascular smooth muscles. So for that, pupillary, pilomotor smooth muscles, and also the smooth muscles of the trigone and the bladder, T and B. And also it is going to act on the liver. So what are the actions that it causes? It is going to increase the contraction in the VEM. It is going to increase the contraction of the vascular and increase the vascular resistance, and it is also going to increase the erection of hair, and it is also going to increase mydriasis, which is the dilation of the pupils, and it is also going to stimulate glycosenolysis. Okay, now let's talk about the alpha 2 receptors. For that, we have the mnemonic of N. So that is for the nerve endings. And please remember that alpha 2 and beta 2 are going to act on the pancreas. So Here we have alpha 2. Alpha 2 is going to act on the pancreas, it is going to act on the platelets, it is going to act on the adipocytes, and the adrenergic and cholinergic nerve terminals, most importantly. So what is it going to do to the pancreas? It is going to inhibit the release of insulin in the pancreas. Okay, and what about the platelets? It is going to stimulate the aggregation of platelets, and it is going to inhibit the release of transmitter, and it is generally going to cause contraction, and it is going to inhibit lipolysis. Now let's talk about beta-1 receptors have an action on H, which is heart, as well as the JG apparatus, which is the juxtaglomerular cells of the kidneys, and it is going to stimulate the rate and force of the contraction of the heart, and also it is going to stimulate the renin release to the kidneys. Now let's talk about the beta-2 receptors. They are going to act on the smooth muscles and the liver and the heart. So they are going to act on the airways, uterine, and vascular smooth muscles. And as I told you before, they are also going to act on the pancreas, and they are also going to act on the liver, and also on the somatic motor neuron terminals for the voluntary muscles, where they are going to cause tremors, and the heart, of course. So they are going to cause the relaxation of the vessels, or the airways, uterus, and vascular smooth muscles. And for the liver, they are going to stimulate glycogenolysis. And for the pancreas, they are going to stimulate the release of insulin. And for this was opposite to that of the alpha 2 receptors. And for the somatic motor neurons, they are going to cause tremor, and for the heart, they are going to stimulate the rate and force. So for that, for the glycogenolysis, lipolysis, I have a mnemonic for you. So please remember alpha 1, alpha 2, beta 2, and beta 3. So 1, 2, 2, 3, alpha 1, alpha 2, beta 2, and beta 3. So alpha 1 is going to cause stimulation of the glycogenolysis. Alpha 2 is going to inhibit the lipolysis. Beta 2 is going to stimulate the glycogenolysis, and beta 3 is going to stimulate the lipolysis. Okay, so beta 3 is only going to act on the adipocytes, and it is going to stimulate the lipolysis. And if we talk about dopamine 1 and dopamine 5, it is going to act on the brain and the smooth muscles of the renal vasculature, and it is going to cause decrease, and it is going to cause the decrease in resistance by increase in the dilation of the brain as well as the smooth muscles of the kidneys. And if we talk about the D2, D3, and D4, they are going to act on the nerve terminals, so they are going to act on the CVS, the smooth muscles as well as the brain, and they are going to inhibit the adenylyl cyclase. Okay, so now if we talk about the endogenous adrenergic receptor agonists, for example, epinephrine, norepinephrine, as well as dopamine, they are catecholamines, and they are rapidly metabolized by COMT, which is catechol-O-methyltransferase, as well as monoamine oxidase, as described in the chapter. If used as drugs, these adrenoreceptor agonists are relatively inactive by the oral route, and they must be given parenterally, which is through IV or IM or subcutaneously. When released from the nerve endings, they are taken up by an EP or DAT, which are norepinephrine transporter or dopamine transporter, into the nerve endings and then into the presynaptic cells. This uptake may also occur with exogenous norepinephrine, epinephrine, and dopamine as drugs. These agonists have a short duration of action. So here we are talking about the directly acting drugs. They have a short duration of action. They are rapidly metabolized by COMT and MAO, and they are taken up by an EP or DAT. Okay, so when given parenterally, they do not enter the CNS in significant amounts. And so, for example, isoproterenol, which was the example that I gave you for the non-selective beta receptors, this is a synthetic catecholamine, which is similar to the endogenous transmitters, but it is not readily taken up into the nerve endings. And if we talk about phenyl isopropylamine, which was the example of indirectly acting releaser, for example, amphetamines, they are resistant to monoamine oxidase, and most of them are not catecholamines, and therefore they have a longer duration of action, and they are resistant to catechol-O-methyltransferase because they are not catecholamines. So PPAs or phenyl isopropylamines are orally active. They enter the CNS. Their effect is longer. Tyramine, which we discussed along with amphetamine, it is going to be rapidly metabolized by monoamine oxidase because it is not a phenyl isopropylamine. It is inactive orally, except in patients who are taking an MAO inhibitor drug. MAO inhibitors are sometimes used in the treatment of depression because if a person is taking depression drugs, then tyramine is not going to be rapidly metabolized. They are sometimes used in treatment of depression because tyramine is found in fermented foods. Patients using monoamine oxidase inhibitors, they have hypertensive reaction to such foods. Now let's talk about the mechanisms of action of the receptors. So alpha 1 receptor is going to act through GQ, and alpha 2 is going to act through GI. Beta 1, 2, and 3 are going to use GS protein. D1 is going to use GS protein, and D2 is going to use GI protein. QISSI. Now let's talk about the alpha receptor effects. So alpha receptor effects are going to be mediated by the trimeric protein, which is GQ. When GQ is activated, the alpha molecule of this protein is going to activate the phospholipase C, which results in the release of IP3 and diacylglycerol. IP3 is anisotol 1,4,5 triphosphate. So these are going to be released from the membrane lipids. IP3 is going to act on the intracellular IP3 receptors to cause release of calcium from stores in the smooth muscle cells. Direct gating of the membrane calcium channels will also play a role in increasing the intracellular calcium concentration. Intracellular enzymes are going to be activated by diacylglycerol like protein kinase C. Alpha 2 receptors are going to result in inhibition of adenylyl cyclase through the coupling protein GI. All of the beta receptors, beta 1 to 3, will stimulate the adenylyl cyclase through the coupling protein GS, which leads to an increase in cyclic AMP concentration in the cell. Some evidence suggests that beta receptor may exert G protein independent effects after binding with beta arrestin. Biased agonists appear to have effects in addition to traditional GS activating actions. Beta arrestin may mediate these actions. Now let's talk about dopamine receptor effects. So dopamine D1 receptor will activate adenylyl cyclase through GS, and it will increase cyclic AMP in the neurons and vascular smooth muscles. Dilation of the vessels will result, dopamine 2 receptors are more important in the brain because they are going to act through GI method. They also play a significant role as presynaptic receptors on the peripheral nerves. They are going to reduce the synthesis of cyclic AMP through the GI routine. Now let's talk about the organ system effects. So on the CNS, catecholamines are not going to enter the CNS. However, some of the drugs which are indirect are going to enter the CNS. For example, amphetamines and cocaine. And cocaine. So what are the adverse effects of these drugs? CNS effects reflect both a noradrenergic effect and the amplification of dopamine's action in the ventral tegmentum and the CNS nuclei. Repeated dosage of the amphetamines is going to result in development of tolerance and dependence. Very high doses is going to lead to marked anxiety, aggressiveness, paranoia, and seizures, AAPS. Overdoses of cocaine is also going to result in seizures. Some alpha-2 selective agonists, for example, clonidine, is going to cause vasoconstriction. If it is given through IV, if it is given through the oral route, it is going to cause decrease in the sympathetic outflow and also decrease in the blood pressure. They are going to be taken up into the CNS and they are going to reduce this. This is done through the alpha-2 adrenoreceptors on the presynaptic nerve endings. Now let's talk about the eye. So the smooth muscles of the pupillary dilator will respond to topical phenylephrine, which is an alpha-1 agonist with contraction and mydriasis, as you can see here. Accommodation is not significantly affected. Outflow of aqueous humor is going to be affected. Aqueous humor synthesis is going to be decreased and intraocular pressure will also be decreased. As now let's talk about the bronchi. So what happens to the bronchi? They are going to relax because if we talk about the beta 2 receptor agonist, then an example of that is albuterol, which is commonly used in inhalants. So that explains it. So isoproterenol and albuterol are the examples of the drugs that are going to cause bronchi relaxation. Beta 2 agonists are the most efficacious and reliable drugs for reversing of bronchospasm. So now let's talk about the GIT. So here we're going to talk about the alpha and beta receptors, which are going to be present in the ENS, which is the enteric nervous system, walls, as well as the smooth muscles. So they are going to cause smooth muscle relaxation there. Alpha-2 agonists are also going to decrease the salt and water secretion into the intestine. Please remember this. Now let's talk about the genitourinary tract. So here we have the alpha receptors and the beta receptors. So alpha receptors are going to be present in the B, T, and S. So in the bladder, the trigone, as well as the sphincters. And also the alpha-1 receptors are going to be present in the prostate gland in the males, and they are going to cause contraction of these organs. If we talk about the beta-2 receptors, then they're going to cause the relaxation of the uterus. They're going to be present in the uterus of a pregnant female. Now let's talk about the vascular system. Different vascular beds will respond differently depending upon their dominant receptor type. So if we talk about the alpha-1 agonists, please remember that S and S is going to contract. So alpha-1 agonists, for example, phenylephrine, will contract the vascular smooth muscles specifically in the skin and splanchnic blood vessels. They're going to contract and they will increase the peripheral vascular resistance and venous pressure. Because these drugs will increase the blood pressure, they will evoke a compensatory reflex bradycardia that is mediated by the vagus nerve or the tense nerve. Now let's talk about the alpha-2 agonists. Alpha-2 agonists, for example, clonidine. So whenever you think of an agonist, just remember an example of that. So alpha-2 agonists are going to cause vasoconstriction when given through IV or topically, but for example, nasal spray. But when they are going to be given orally, they are going to accumulate in the CNS and they are going to reduce the synthetic outflow and the blood pressure. Now let's talk about beta agonists. Beta 2 agonists, for example, albuterol and metaproterenol, as well as terbutaline, they are, and the non-selective beta agonists, for example, isoproterenol. They are going to, so to remember this, please remember ATM, albuterol, metaproterenol, and terbutaline, and non-selective isoproterenol. They are going to cause reduction in the arteriolar tone and also reduction in the peripheral vascular resistance and reduction in the blood pressure and the reduction in the arteriolar tone in the skeletal muscles, muscular bed, and so on. But when we talk about beta-1 agonists, for example, dopamine, they are going to be potent cardiac stimulants and they are relatively less effective on the vessels. Now let's talk about dopamine. So dopamine is going to cause vasodilation in the splanchnic and the renal vascular beds. As you know that D1 is going to be present in the splanchnic nerves as well as the kidneys. This can be useful in the treatment of renal failure associated with shock. At higher doses, dopamine is going to activate beta receptors which are present in the heart, and elsewhere at even higher doses, alpha receptors are going to be activated. Now let's talk about the heart, which is well supplied with beta 1 and beta 2 and predominant to beta 1 receptors. It is going to cause increase in the rate of cardiac pacemakers, chronotropic, inotropic, and as well as a donotropic effect. Now let's talk about the net cardiovascular actions. Sympathomimetics with both alpha and beta effects. For example, norepinephrine. They are going to cause reflex increase in vagal outflow because they increase the blood pressure and evoke the baroreceptor reflex, BBB for that. This reflex vagal effect will dominate any direct beta effects on the heart rate, so that a slow infusion of norepinephrine is going to cause bradycardia. But if the reflex is going to be blocked, for example, by a ganglion blocker or antimuscarinic drug, norepinephrine is going to cause a direct beta 1 mediated tachycardia. A pure alpha agonist, for example, phenylephrine, routinely slows the heart through the baroreceptor reflex. whereas a pure beta agonist, which is isoproterenol, will increase the heart rate. Diastolic blood pressure is affected mainly by peripheral vascular resistance and the heart rate. Heart rate is important because the diastolic interval will determine the duration of outflow of blood from the arterial compartment. Adrenoreceptors with the greatest effects on the vascular resistance are alpha and beta 2 receptors. The pulse pressure is going to be systole minus diastole. It is determined by the stroke volume, which is a function of the force of the contraction of the heart, which is influenced by beta 1 receptors mainly. The systolic pressure is the sum of diastolic and pulse pressure, and it is a function of both of the alpha and beta effects. Now let's talk about metabolic and hormonal effects. Beta 1 agonists will increase the secretion of renin. Beta 2 agonists will increase the secretion of insulin. They also increase glycosenolysis, as we know that alpha 1 and alpha 2 are going to cause increase in glycosenolysis and decrease in the lipolysis respectively. And if you talk about beta 2 and beta 3 receptors, they are going to cause increase in the glycosenolysis and increase in the lipolysis respectively. Okay, so beta 2 agonists are going to increase the secretion of insulin, and they will increase the glycosenolysis in the liver, and the resulting hyperglycemia is countered by the increase in the insulin levels. Transport of glucose out of the liver is associated initially with hyperkalemia. Transport into the peripheral organs, specifically the skeletal muscles. It is accompanied by the movement of potassium into these cells, resulting in a later hypokalemia. All currently available beta agonists are going to stimulate lipolysis through the beta. Let's talk about 3 drugs here. So we have phenylephrine, and then we have isoproterenol, and then we have norepinephrine. So what is the effect on the skin splanchnic vascular resistance? So please remember SM renal for the phenylephrine. So phenylephrine is going to have a very large increased effect on the skin and the splanchnic vascular resistance, and it is going to have a moderate increase in the case of mean blood pressure, and it is going to have small increase in the renal vascular resistance, as well as a small increase in the skeletal muscle vascular resistance. And it is going to, most importantly, phenylephrine is going to decrease the heart rate because of compensatory reflex response. Now let's talk about isoproterenol. Isoproterenol is going to have an effect only on a few organs. So it is not going to have any effect on skin, splanchnic vessels, or the kidneys, but it is going to have an effect on the skeletal muscles as well as the mean blood pressure and the heart rate. So what is it going to do to the skeletal muscle vascular resistance? It is going to moderately decrease the skeletal muscle vascular resistance, and it is also going to moderately decrease the mean blood pressure. And what is it going to do to the heart rate? It is going to increase the heart rate. Isoproterenol is going to increase the heart rate. Now let's talk about norepinephrine. It is going to cause a very large increase in skin and splanchnic vessel resistance, and then it is going to cause a large increase in the mean blood pressure, and then it is going to cause a moderate increase in skeletal muscle vascular resistance, and it is going to cause very small increase in the renal vascular resistance. For the heart rate, please remember that it is going to cause decrease in the heart rate due to the reflex compensatory response, and it is going to increase the heart rate in case of direct response if the reflexes are blocked. Isoproterenol is going to cause a very large increase in pulse pressure, and norepinephrine is going to cause small increase in pulse pressure. Here we can see that the pulse pressure in case of norepinephrine is going to be very high as compared to the isoproterenol, and the heart rate is going to be very low in case of norepinephrine, but isoproterenol is going to cause a very large increase in the heart rate. Now let's talk about the clinical uses. So for anaphylaxis, what are you going to give? Please remember EA for that. So we're going to give epinephrine, which is the drug of choice for anaphylaxis, which is characterized by hypotension, bronchospasm, and edema. Because it is an effective physiological antagonist of many of the mediators of anaphylaxis, antihistamines and corticosteroids can be given, but neither is as efficacious or as rapid acting. So the critical need for epinephrine is readily in the injectable form. For anaphylaxis, it has called attention to recent price gauging for the standard product. Now let's talk about the drugs that we use in the CNS. So first of all, we have cocaine, and then we have methylphenidate, and then we have the amphetamine. So if we talk about the phenylisopropylamine, then we have the example of amphetamine, which is commonly used for elevation of mood, and legitimate indications are weight loss and narcolepsy, but weight loss is not going to be maintained unless your dietary habits are also changed. And we are going to give methylphenidate for ADHD or attention deficit hyperactivity disorder, and clonidine is basically given for hypertension, and it is going to reduce the benzodiazepine withdrawal symptoms. However, the bad effects of clonidine are that it is mainly used for mood elevation, but it has a liability for addiction. Now let's talk about the drugs that we give for the eye. So first of all, please remember PT, BAT, which is a mnemonic for this. So phenylephrine and tetrahydrozoline. They are going to cause mydriasis, and they are going to reduce irritation, and they are going to reduce congestion. Now let's talk about the other drugs, which are B and A. So first of all, we have brimonidine, and then we have apraclonidine. They are used to treat glaucoma. Now let's talk about bronchi. So for the short-acting drugs, we are going to have ATM. So A for albuterol, T for terbutaline, M for beta-proterenol. Now let's talk about the long-acting beta agonists, or the LABAs. So these are, the mnemonic for this is the fossil. So F for formoterol, O for olodaterol, S for salmeterol, and I for indacaterol, and L for vilanterol. So they are going to be given for asthma or chronic obstructive pulmonary disease. And they are also used in combination with corticosteroids or antimuscarinics for prophylaxis in asthma or COPD. They are not indicated for the treatment of acute symptoms. They are used for the treatment of chronic symptoms. But let's talk about the cardiovascular applications. So for this, please remember the mnemonic of NDD. N is norepinephrine, which is used in the conditions of shock. So for example, a girl named Noor, she was shocked by her marks. So norepinephrine is given in shock, and then we have dopamine, then we have dobutamine. So for dopamine is going to be preferred over to norepinephrine because it is going to increase blood flow to the viscera and the kidneys. And dobutamine is used to increase cardiac output in chronic heart failure. So the conditions in which an increase in blood flow is needed. In these conditions, we are going to give these drugs. In acute heart failure and some types of shock, an increase in cardiac output and blood flow to the tissues is needed. Beta-1 agonists are useful in this situation because they increase the cardiac contractility and reduce afterload by decreasing the impedance to ventricular ejections with beta-2 effect, which is small. Norepinephrine is, in contrast to earlier recommendations, is an septic and cardiogenic shock when used properly. Then we have dobutamine and dopamine. They are also used. Unfortunately, the arrhythmogenic effects are dose limiting. Now let's talk about the conditions in which we need a decrease in the blood flow. So for this, we are going to use norepinephrine and phenylephrine. So alpha-1 agonists are used in vasoconstriction. These include local hemostatic epinephrine and decongestant phenylephrine. As well as for shock, we use norepinephrine and phenylephrine. In this temporary maintenance of blood pressure is used to maintain the perfusion of the brain, heart, and kidney. High doses of vasoconstriction will worsen the shock due to septicemia or MI because cardiac reserve is marginal. In the administration of local anesthesia, alpha agonists are often mixed with the local anesthesia to reduce the loss of anesthetic form from the area of injection into the circulation. Chronic orthostatic hypotension is due to inadequate sympathetic tone. It can be treated with oral ephedrine, which is going to increase the sympathetic tone, or a newly orally active alpha-1 agonist, which is midodrine. Then we have conditions in which acute cardiac stimulation is going to be needed. So for that, we are going to need isoproterenol as well as epinephrine. Epinephrine is used in cardiac arrest by intravenous and direct intracardiac injection. And then we have isoproterenol, which is going to be used for AV block. Now let's talk about the drugs that we are going to use on the genitourinary system. So for that, please remember RT, T is for terbutaline, and R is for ritutrine. They are going to suppress premature labor, but the cardiac stimulator effect with arrhythmias is hazardous to both the mother and fetus. NSAID drugs, calcium channel blockers, and magnesium are used for this indication. Long-acting oral sympathomimetics, such as ephedrine, and are sometimes used for improving urinary continence in the elderly and in children with enuresis. This is mediated by alpha receptor in the trigonal bladder and in the smooth muscle phosphate. Now let's talk about toxicity. And also, please remember the drugs which are used for decreasing blood pressure and causing bradycardia. These are IDEA, isoproterenol, dopamine, epinephrine, as well as atropine. Now let's talk about toxicity. Because of their limited penetration into the brain, what can catecholamines do? So they can cause vasoconstriction, they can cause hemorrhagic stroke, they can cause arrhythmias, they can cause myocardial infarction, and they can also cause pulmonary edema or hemorrhage. Now let's talk about the toxicity of phenyl isopropylamines, or PPAs. They are going to do what? They're going to cause CNS toxicity. In small doses, they are going to cause nervousness, anorexia, and insomnia. In high doses, they are going to cause aggressiveness, anxiety, as well as paranoia. This is going to lead to convulsions. Alpha-1 toxicity is hypertension. Beta-1 toxicity is sinus tachycardia and sinus arrhythmia. Beta-2 toxicity is skeletal muscle tremor. It is important to know that none of these drugs are perfectly selective. At high doses, beta-1 selective agents have beta-2 actions and vice versa. Cocaine is of special importance as a drug of abuse in its major toxicities, including cardiac arrhythmias or infarction and seizures. Fatal outcome is more common with acute cocaine overdose than with any other sympathomimetic.